Well, hello, everyone. I will be presenting one of the 3 papers that I completed for my dissertation recently while I was finishing my PhD at Boston College. So a quick thank you to the members of my dissertation committee, none of which are here, of course, but some of which have worked closely with this lab in some way, shape, or form in the past. So I'm going to skip over some of these beginning slides, which are not new knowledge to anyone in this room. There's a huge care gap in terms of mental health and psychosocial well-being needs. And we see this globally, but in some parts of the world more than others. And of course, task sharing use of non-specialist providers to deliver evidence-based interventions has emerged as a strategy that is both feasible and effective in terms of seeing the mental health outcomes that we want to see. So the 2 gaps that I found while doing my literature review to prepare for my dissertation that were relevant to this study is I was really interested in looking at how quality of delivery, both competence and fidelity of non-specialist providers, was associated with intervention outcomes in mental health and psychosocial support studies. So to what degree does delivering an intervention better lead to better outcomes? Theoretically, it's obvious, but I saw a big gap in the literature of studies that were examining this research question, particularly low resource settings. And the studies that were doing this, I didn't think were conceptually being accurate with their idea of quality of delivery. So really defining quality of delivery as both competence and fidelity, fidelity being the adherence to the intervention manual, and competence being those general soft skills of quality of delivery, like showing empathy, active listening, building rapport, skills that are relevant in all mental health and psychosocial support interventions. So some studies would talk only about fidelity or only about competence, and rarely did I see these being examined holistically in terms of the broader idea. Although I will say that when I did a systematic review to see how quality of delivery was being measured, one of the only 5 studies that were looking at both quality of delivery as fidelity and competence was by Daisy Singla, highlighting the Thinking Healthy program and the therapy quality scale. So that has to do with a lot of the work in this lab, so shout out to that. And I saw no studies in low and middle income settings that were testing the examination of quality of delivery and mental health and psychosocial support outcomes. So I did see this research question being answered in high income settings. Specifically, a recent meta-analytic review was released and has been done often in studies with education outcomes, but no studies in low and middle income settings that were looking at how quality of delivery is associated with better mental health outcomes in studies. So the study that I did took place in Rwanda, so I'll provide a little bit of context before going into my own methods and the purpose of this study. So most people know Rwanda from the 1994 genocide that took place. This was over 30 years ago now. I will say that this has profoundly shaped the landscape of Rwanda. The study that I'll be talking about today is a parenting intervention. So many folks that were children when this happened grew up without parents or orphaned, losing one or both parents from the genocide. In 1994, there were over 800,000 individuals killed. That included 75% of the Tutsi population being killed, which was a little bit over 10% of the total population of Rwanda. So very significant loss, and you still see this. And a lot of people are now parenting, having never learned how to be a parent really from their own parents because of the losses that they faced in those early days. So Rwanda does see high rates of violence and psychosocial challenges, especially in families living with extreme poverty. But Rwanda is a situation where there's high government investment. There are a lot of donors that are really interested in working in Rwanda. And that's because the government and a lot of agencies that are Rwandan working in Rwanda are very invested in developing social policy and funding interventions that support families and other folks that are living in Rwanda in poverty. So I'll be discussing briefly the development of Sigirimyango, which means in Kinyarwanda, strengthening the family. This intervention was developed by Teresa Betancourt, who was my doctoral advisor, to promote early child development and prevent violence in families living in extreme poverty in Rwanda. Rwanda has a variety of poverty categorization. So Ubudehe 1 families refers to families that are living, categorized by the Rwandan government as families living in most extreme poverty in Rwanda. And the intervention is unique in that it does not just target mothers for parenting, but also secondary caregivers, which includes all family formats that you would see in Rwanda or anywhere. So it's designed to work well with fathers, with foster parents, with grandparents, anyone who would be reasonably caring for children in the home, which, as we know, in many parts of the world, including the US, it's not just a mother's job, it's really the whole family, and it takes a village to raise a child. So we work in Rubavu, Ngoma, and Nyanza districts. I can talk more about why later. And this intervention is aligned very closely with the government of Rwanda existing policy initiatives. So for example, Rwanda has a very comprehensive early child development policy that has pillars that directly relate to components of Segura Miongo in terms of what parenting should look like in Rwanda. The format of Segura Miongo is it is 12 modules. Each of them are designed to be between 60 to 90 minutes each. It's a home visiting format, so the non-specialists that are delivering this intervention, in a minute I'll tell you more about them, are going into families, sitting with their caregivers in their own homes, and delivering this intervention without people having to leave. So it's not group-based, it is specifically just the family and the non-specialist provider in that moment. And each of the sessions includes a 15-minute active play session, which is where there's some serve and return interactions, and the non-specialist is using active coaching to kind of guide the parent into what it's like to interact with their young child in a really healthy way. So Segura Miongo, first, this is right before the pandemic, was implemented as a cluster randomized controlled trial just to test the intervention for families that are living in extreme poverty. This was tested alongside a lot of the poverty reduction work that was already been doing in Rwanda by the government of Rwanda. So they had some cash for work initiatives that had some gender sensitive components. So the cluster randomized trial was really embedding Segura Miongo and targeting the same families that were already targeted by the poverty reduction strategies going on in Rwanda. It was effective, and I won't go into all the effects that we saw, but some of them are just greater improvements in responsive caregiving, decreased violent discipline practices being used by caregivers in the home, increased dietary diversity, increased shared decision-making between mothers and fathers in the home, a range of psychosocial well-being and child development outcomes. This was later scaled up with a hybrid type 2 trial, so testing a new delivery strategy. Also, there was an embedded effectiveness trial in our hybrid type 2 implementation effectiveness trials. This was after the pandemic, and this was now very big. So in the past, there were a little bit less than 300 families that were in the CRT, but with the hybrid type 2, it scaled up Segura Miongo to nearly 10,000 households that were Ubudehe 1 households in those 3 districts of Rwanda. So the purpose of my study was, like I said, to examine the association between quality of delivery in Segura Miongo and changes in key psychosocial outcomes in Segura Miongo. So I won't go into it in a lot of depth, but I'm happy to answer more questions later. So the non-specialist providers in Segura Miongo are affiliated with the government of Rwanda. They are a child protection workforce that are affiliated with the Ministry of Gender and Family Promotion. So this was a change from the non-specialists that were involved in the original CRT. And the change was made because it was important for us to then be working with non-specialists that already had a link to the government, just because they had a lot of other roles in the community. And being trained in Segura Miongo, they would be able to then take those skills into other interventions and other work they were doing with families that were already associated with their work, and they were being paid through the government of Rwanda. And they were largely, I took out the slide on this, but I should have kept it in. They're about half female. Most of them only had a primary school education. So I hypothesized that there would be an association between both competence and fidelity and key intervention outcomes, which were responsive caregiving and child discipline practices in the home. I included all households that were in the embedded trial. So we did not collect effectiveness data on everybody in the Play Collaborative study. So this was a hybrid type 2 study. There were only 231 households enrolled in the embedded effectiveness trial. A little bit of attrition over time, but not a lot. Primary caregivers in the home largely had primary or less education, pretty evenly split by gender. The average age was around 32, but there was quite a big age range. And just because of these outcomes that were reported that I was looking at, that was self-report data from only the primary caregiver. So only primary caregivers are included in the study. But once again, this intervention is really intended to target all caregivers in the home. There's other data that just doesn't correspond to my research question about secondary caregivers. So the way that responsive caregiving was measured was the home observation for measurement of the environment. This is a measure that was validated in Uganda and had previously been used in Rwanda in some of our work. This is an observational measure, has 6 parts: parental responsivity, acceptance of child, organization of the environment, learning materials in the home, parental involvement, and variety and experience provided to the child. Most of the response options are binary, and there's one question that has a frequency option as well. So I use a summative score. And I'll talk more about limitations of this measure later, but a couple things that I found difficult about working with the home was that it was a binary response option, so just yes, no, instead of like a Likert scale. So it's either caregiver self-report or observational. And as we know, self-report sometimes won't give you the most accurate data. And then child discipline practices was measured with the multiple indicator cluster survey child discipline module. This was the 5th version that we were using. It's now they're working on the 7th right now. So some parts of that are important about the multiple indicator cluster survey to know. It's also caregiver self-report, and it assesses prevalence of a few different types of child discipline practices, nonviolent discipline, which can be split up into explaining why the behavior is wrong to the child, but we're targeting children 0 to 2. So UNICEF will say only use this with children 1 and above, but it works a lot better for children that are a little bit older instead of in that 1 to 2 age range. And other parts of other parts of the mix include physical aggression, psychological aggression, and then deprivation, which could include taking away toys or playthings from the child, or else food. So I'll talk about some of the limitations of the mix a little bit later as well. But you can already maybe point out some of the issues that you could see with it. Both of them are only moderately reliable in our data. And then the key independent variables are quality of delivery, so fidelity and competence. This was taken from a quality of delivery checklist. And so there was no ability in Rwanda at the time to do, it didn't have like a virtual setup where everything could be recorded. It was audio recorded, but a lot of the quality of delivery scores that we were getting is from in-person supervision sessions. And so it would be a supervisor of the non-specialist provider that was visiting the home, and there were 12 sessions. Most non-specialist providers received 6 in-person supervision sessions. So we had 6 scores per non-specialist provider of quality of delivery. And this was longitudinal data spanning from module 1 going all the way up to module 12. So used average scores across the 12 modules to compute quality of delivery variables. And then because there were different numbers of quality of delivery items on each of the checklists, then converted them to percentages for the purpose of comparison. I can talk more about why and some of the pros and cons of doing this a little bit later too. So both competence and fidelity items were rated on a 5-point Likert scale that ranged from 0 to 4. And there were 16 cross-cutting competence items. And for fidelity, there was only 1 to 5, depending on the module. Some modules only had 1 fidelity item. This is a 60 to 90 minute session. And so that ended up being a little bit of a challenge too. Obviously 1 or even 3 items doesn't really fully capture the fidelity to what we were expecting to be seeing in that session on behalf of the non-specialist provider. Some example competence items are using active listening, praising and encouraging the caregivers, appropriately using the Seguro Miongo manual. That one I found a little bit interesting because I think it can actually spill into the definition of fidelity a little bit too. And the EZU engaged, EZU was a non-specialist provider, engaged the family in a discussion about the module topics and encouraged participation from all caregivers. So some example fidelity items from module 11. The EZU reminded the caregiver that for a baby's brain to grow, the baby needs opportunities to play, practice new skills, see new things, copy what others do. And the EZU discussed the importance of having a clean, safe, and supportive home environment. One of the things that I found challenging about our current fidelity items that we use is that a lot of it was just going to capture sort of the responses that you would want and easier to have to families. This was a lot of serve and return. They're in the homes for 90 minutes. A lot of what we wanted them to be doing is responding accurately in those active play sessions and really guiding the caregiver. But a lot of the fidelity items were more like, did you say this one time? Did you discuss this briefly? And there were other issues that came up in terms of how's that actually really conceptualized? What does it really look like for an EZU to do that well? We found some challenges with supervisors defining that quite differently, which was a limitation that I experienced in this study. Before my data analysis, I used multi-level logistic growth and mixed effect growth models. There was a lot of nesting in the data just in terms of geography. And then also there were families, well, a certain number of supervisors supervising non-specialists, the non-specialists working with an average of about 3.5 families each. So we saw nesting in that way as well. Use restricted maximum likelihood, and We treated district as a fixed effect, just represented by dummy variables in the model, and controlled for a lot of time invariant demographic variables like level of education for the caregiver, their age at baseline, the age of ESUS, which was significant in another one of my papers, looking at factors associated with quality of delivery scores, and did not use gender because 100% of the primary caregivers were female in this study. The results that I saw were a little bit surprising to me at first. So for responsive caregiving, there was a significant association between ESU competence and acceptance of the child. And acceptance is defined as acceptance of undesirable behavior and avoidance of restriction and punishment, and how the parent disciplines the child. Learning materials is defined as the presence of several types of toys and activities that are available to the child in the home. Also, if they're age appropriate and directed towards intellectual development. So those were the only parts of responsive caregiving that we saw significantly associated with competence scores, and nothing for fidelity. So fidelity is not significant. For child discipline, so for each additional percentage point of ESU competence, then the primary caregivers had on average a 5% decrease in the odds of using physical punishment for child discipline. And none of the other child discipline results were significant in the study. So overall, we saw that there were some effects where ESU competence was associated with caregiver decreases in physical punishment as a discipline tactic, higher acceptance of the child, and more learning materials in the home, and no effects with fidelity. So I thought that was interesting because theoretically you would assume that both competence and fidelity would be associated with all intervention outcomes. If someone's really adherent to the manual, but they don't show active listening, they're not empathetic, they're not a good communicator, probably not going to be a very effective deliverer of an intervention. And likewise, if someone is a wonderful person, they're very calm, they're empathetic, but they don't really know the components of the intervention very well, they're not trained well, it also might not be very successful. And once again, I have quite a few study limitations in terms of conceptualization and measurement, but so that could have led to findings that were not true. But this finding that competence is more highly associated with intervention outcomes rather than fidelity, I did see in a couple other places. One being a recent 2022 systematic review and meta-analysis found 62 studies that tested clinical effects of adult psychotherapy treatments, and this is in high income settings. And they found that competence was associated with clinical changes, but fidelity was not across the 62 studies in general. So the clinical outcomes are extremely mixed: alcohol use disorders, PTSD, anxiety. So that sort of aligns with the idea of therapeutic alliance, that there has to be that connection between the therapist and who they're seeing. Or I also saw this in qualitative data, which I won't discuss now, but in my third dissertation paper, looked at interviews for the non-specialists delivering an earlier part of Sigir Miongo in the CRT. And this was not a study I was able to do myself, so the guide was a little bit limited, but the CBVs were discussing, those are other non-specialists, they were discussing that a lot of their competence skills they found to be a little bit more effective in terms of the changes they were seeing in families. They were tying it back to their competence skills and the rapport they already had built with members of the community more than their fidelity skills. So we did see this confirmed a little bit in qualitative data and then in some literature in high income settings as well. However, quite a few study limitations which have led to really interesting discussions in my old research lab at Boston College about what we should do differently moving forward in terms of measuring fidelity and competence, and even using the mix and the home inventory as well to look at child discipline and responsive caregiving. So there, with quality of delivery, so this is the fidelity and competence measure, there were pretty limited response options. Well, I guess just skewed response options. So on a scale of 0 to 4, 3 was average, which I found to be a little bit odd and led to some ceiling effects in the data. There are also limited fidelity items. So like I said, some modules, there are 12 modules, some of them only had 1 or 2 fidelity items associated with the entire module. So I don't think we are properly conceptualizing what fidelity should have looked like as a non-specialist was delivering those modules. And then even the conceptualization of competence and fidelity. So if you, and I can pull them up later, look at entire competence part of the checklist, entire fidelity part of the checklist, there are certain parts where there's a competence item that looks like it should be a little bit more like fidelity. And I think it's in the wrong spot. And likewise for fidelity. So there wasn't a lot of work done upfront at this time to really properly conceptualize. And if it's not conceptualized well, it will not be measured very well either. Saw similar issues with reliability for the effectiveness outcomes we were measuring. So the response options are binary. So that presents a limitation because oftentimes there's no room for gray area then. If it's fully yes or fully no, and you have to decide. They're both self-report. I had some challenges with operationalization in terms of the mix, specifically for the deprivation part. So if you're depriving a child of food or a plaything, that can look really different. And if in a really low resource setting, usually depriving a child of food is not usually a good thing for child development. I can't really think of any time that it would be. But perhaps if your 1-year-old's playing around, like hitting their sibling with something, you take the toy away, replace it with something else, that could be a good parenting technique, something that they would be coached on. So in terms of what we actually wanted to see in terms of child discipline practices, I don't think the mix was the right tool. And we had a lot of discussions around this. This is developed by UNICEF. They're always improving it. They have a new version that's coming out very shortly. And I think the way that we were using it presented some limitations with the way that child discipline was being operationalized in the study. And then of course, with social desirability bias, oftentimes the caregivers self-reporting on their child discipline practices and their responsive caregiving practices, which could lead to over-reporting of some of the better child discipline and parenting practices and under-reporting of some of the ones that we perceive to be undesirable. So there are ongoing improvements to the quality of delivery checklist that I think are important to discuss. So there's been a lot of work done with Brandon Court's team and others with War Child that have been developing different iterations of the ENACT scale. There's already WEACT and now they're moving into FAMACT, which is a family-based competence scale. And so Teresa has been consulting on that, and one of my other dissertation committee members is as well. So competence will now be measured with FAMACT instead, which I think conceptualizes competence a little bit better. They've shifted the response options to a 3-point Likert scale, which there's more discussion to be had around that, but essentially gets rid of the average score being on the end and causing a lot of the ceiling effects that we saw in the data. And fidelity items have been changed. There was an interesting moment where there was an external evaluator come into Seguro Miyongo, and they used our same tools, and we got extremely different results from our supervisors of the non-specialists that were employed through our study and their raters. So identified some inter-rater reliability issues, and when really talking to our team saw that, oh, we have a lot of variation in the way that a supervisor interprets some of the things that we're seeing on the quality of delivery checklist. So it's really led to improvements in training and training people to be supervisors that's happening in Rwanda right now. And a change in a lot of the fidelity items too that were identified through the lack of inter-rater reliability that we saw. And it has not been piloted yet, but I would really think that this is a dissertation study using secondary data that exists. So I'd be really curious to see, after they have it retested these tools and expanded the study, to retest the same research question and see if they got the same results, because I have to interpret everything extremely cautiously giving measurement limitations. But even so, there's still some practice implications and implications for future research for this study. So first of all, I think a huge need for psychometric studies to test quality of delivery instruments before they are then used. I think we were using some studies or some tools from the early phases we started to not feel great about as a team. And if we had identified some of these issues before implementing Seguro Miyongo, it could have led to, in my opinion, a lot better data. And then in order to really continue to build implementation science theory, I'm curious why this question has not been asked more. So if competence really is repeatedly more associated with intervention outcomes than fidelity, I'd be curious to see if there's differences in where that's happening in different types of interventions, and also why that would be the case. So using mixed method studies to really unpack that finding. And if it tends to be the case, and it's not a measurement issue, that competence has a stronger association with intervention outcomes than fidelity in these types of interventions in these types of settings, then that could have training and mentorship and supervision implications for non-specialists working on mental health and psychosocial support interventions. I don't think you can divorce the idea of fidelity from competence. It is still important, but perhaps really, really focusing and honing in on the skills that are being used, such as empathy, active listening, communication, using role plays, and weekly supervision meetings. So if competence is that important, then just makes it a really big case that should be included along with fidelity, and it isn't always. So thank you very much, and I'm happy to answer any questions.
Hey, we've got a lot of people in our group who work in the area of competence and quality. It's, as you know, a very central question, research question for a lot of the work we do, not just Empower. And indeed, I think it's one of the most important questions in the area of scaling up mental health care, implementation science in that field. So all of this is really extremely important, experience that informs critical issues about measurement. This is very methodologically a very difficult area. How do you actually measure something that is a human interaction without biasing without the measurement process itself biasing what is being measured? But first of all, just some questions from Laura before I have some comments of my own. Diane.
Maybe I missed because I went quickly through the variables that you controlled for, but I was wondering, maybe you did, but just to confirm, if you controlled for economic factors, marital status, and also for all the interventions that these students may be receiving, for example, cash transfer or even mental health assistance, once they join this program, if they were assisted in other ways as well, if there were other interventions that could be good funding. Mm-hmm. And also for family size, I was asking myself if you control by the number of kids, because as I would guess that as more kids, this mother has more stressful, it might be more work. So I was wondering if you control for that, or at least broke down your analysis to see if it's more effective in smaller, if it's smaller family or bigger family, or 2 kids, 4 kids.
Yeah, that's a really good question. In terms of economic factors, they were all a very homogeneous sample because they're Ubudehe 1 families in Rwanda, so they're all very, very poor in Rwanda. So there wasn't a lot of variation that we saw there. So for that one, no. For your other ones, I did try, and I ran into some models that my sample size was too small, essentially, to look at different subgroup analyses. So I had just a little over 200 and was using multi-level growth models. But it is a question we're examining in a longitudinal study of this same intervention. So specifically, we're looking even with qualitative data to see if there's some spillover effects with other children in the home, and if caregivers are feeling like the number of children that they have is affecting, and in what ways, how their parenting skills that they learned in Segura Miongo 4 years after the intervention. So there should be some publications coming out on that soon. And then what was the other thing that you asked about? Marital status? Yeah, I had that same issue, I guess, with I did not do that with the subgroup analysis just because I ran into some model convergence issues, but by far they were all married and had a secondary caregiver in the home that was male. So that was the majority.
Maybe I would even try to ask if the partner actually live in the same household, and also the age of the mother. Did you check that as well?
In terms of controlling for it? Yeah, I did control for the age of the mother. Mm-hmm.
And did you break down to see if the intervention is more effective among younger or older?
And so for that wasn't really my research question, but in terms of others that are looking at just the overall effectiveness of Segura Miongo, there have been more analyses like that. And I don't believe that age was very significant in terms of the effectiveness of it. So I can share some of the publications that are coming out. There should be some in press very shortly.
Yeah, I just wanted to follow up on the question.
Just speak a little louder, Moses. You're too soft.
Regarding the caregiver. So I wondered, I know you've mentioned about the limitation for subgroup analysis, but could you maybe speak to around the type of caregiver? So in the context of Rwanda, as it is for Kenya also, the primary caregiver might be a grandmother and a biological parent.
In this case, that is very true. And all of ours were the biological mothers that were listing themselves as the primary caregivers. Who the secondary caregiver was, we saw a little bit more variation was. I believe about 75% of them, it was father, and others were listing a grandparent or a sibling as a secondary caregiver. I did not really look at that a whole lot for this study because the data I was using was self-reported by the primary caregivers. And so I didn't have anything to bring into the model about secondary caregivers, but those that are looking at other questions of effectiveness around the study have examined that a whole lot more in depth. And I can share more about that after this.
So I just wanted to, while we, wait for some more questions. The first thing I want to ask you, Laura, is why did you all not consider using a child outcome as your primary outcome rather than a process outcome, such as, especially one that is so difficult to measure reliably?
The process outcome being quality of delivery?
No, the parent, your outcome was the home tool, which is a parenting quality tool. And then you had self-report on discipline, which, as you rightly point out, is going to be it's very hard for any parent to say, I beat up my kid, to a researcher, research assessor. So I wondered, given that you have ECD out, I know this trial very well.
Yeah.
You have ECD outcomes. So why didn't you just use the ultimate child outcome in these analyses and ask the question, was the quality of the delivery of care or the competence predicting the actual child outcome?
We are doing that next, and it's largely just because of my own streamlining for my own dissertation, but I do think that it makes a lot of theoretical sense, and as I'm publishing, we're bringing some of that in. I will say that mostly I was interested in framing it still as a psychosocial support outcome, just because of the work that I'd done leading up to this study, and then matching with some of my other dissertation interests. So I wanted to still keep it in the realm of psychosocial well-being, whereas if I were to get into like dietary diversity, it wouldn't have matched as well with my research I've done up to that point. So it was somewhat of a logistical issue, but definitely moving forward, we are going to do that. And these are Teresa was also interested in keeping it some of the main outcomes, the primary outcomes, I guess we'd identified for the study. So there's a lot of child development outcomes that were secondary outcomes as well. So for that, I was trying to pick from the primary outcomes that were still in the range of psychosocial outcome. But it is a really good point that theoretically moving forward, that for publishing, we would do that.
Yeah. And the second question I had is, had you to do this again, would you try and get as it were, a true record of what happened in the sessions as a measure of quality rather than a self-rated checklist? By true record, as you know, in MPower, we put a lot of emphasis on audio recordings.
We do have audio recordings.
So have you tried to run those past a sort of independent assessment of fidelity?
We could have done that. They were all audio recorded, and that was for self-reflection, and so supervisors could go back and listen to them. And still, the only ratings that we have are for when a supervisor visited in person and filled it out themselves. So somebody could do that retroactively, right, and it hasn't been done. And even when an external evaluator had come in, they went in person to the homes and they were watching what's happening in the homes rather than listening to the audio recordings. And so it's something that could be done because we have the audio recordings for all 12 of the sessions that each one did. And as they're thinking about continuous enrollment model and continuing to expand to year Miongo, there are those conversations, but we haven't been able to do that yet. I think it's just because of probably workforce issues where everyone's so bogged down with what they're doing, they don't go back and listen, but it is important that they could.
So one thing that I just wanted to alert people in our lab, John can speak more to this, is that the question of the workforce to actually do quality monitoring is a really important barrier. It's not a small issue to sit and listen to recordings and rate them. But with the advent of large language models, it could be a leapfrog moment for quality assessment. And if you have sufficient data, at least on paper, this is how it would work in theory. If you had sufficient audio recorded data of sessions and you had an outcome, then you could actually train a large language model using the audio transcribed data without even any theoretical model. It's just data driven, and develop an algorithm and then examine whether it can predict in a test in one half of the sample or whatever the size is. And we're trying to do this in Texas with the Magi, with the data. Also in India, where in the Optimize D trial, we're collecting thousands of psychotherapy session data audio recorded with independent patient level outcomes to see whether we can generate automated large language model quality scores. And that could then potentially be something that you can then incorporate in routine implementation.
Are there barriers for language? Like,
I checked at least with large language models, they're actually language independent agnostic. The only thing that matters is they have to be, they're not language agnostic. No, you have to have a transcription.
Right.
So the language, the audio is first transcribed. I would imagine, what is the language in Rwanda?
Kinyarwanda.
I don't know about Kinyarwanda, but
Yeah.
Swahili definitely is that there are automated systems for transcribing, and then it's translated if you want into English, or you can analyze it in the original language. But it's something to explore.
Yeah.
Because if you've got all these data, that is to say you've got the audio recorded data and you have the child level outcomes, actually that's a gold mine, because for most people, they don't have the data.
Yeah.
And so this would be something that a data scientist would be really good person to speak to, whether you can run these data, you can run these models with the data you have.
I was wondering if the sex of the child also influences if it's a boy or a girl.
You can analyze that too. Yeah, you can. Those are
Interesting.
different kinds of moderators. You mentioned the mother's age. That's a really good example. Actually, it's a dyad. Parenting is a dyadic relationship. So of course, the child also has an influence on the parenting relationship. A child who has a temperament which is perhaps not one that easily settles. There's a good literature that those kids often have a lot more disciplinary issues. So the parent may come across as disciplining the child, but the child's behavior is also part of that mix. It's not independent. Gloria had a question, and then and Sarah, and then we're gonna move
Sure.
on.
I was just gonna offer, I can just talk with Laura later if it
Go on.
helps to save time. So I had one clarifying question and then just a couple of comments. So if you could just remind us again, so how often were these, how many sessions were recorded per provider, and how long over time is when you decided to do the assessment, and how many times was the quality measurement that you've said measured per provider? Does that make sense? Was it just once? Was it 2 weeks after? Was it after they had some supervision?
So it was for all 12 modules, there's audio recording. There may be some missing data because someone forgot to press record, but they had their audio recording with them for each session. So the supervisors were required, at first it was supposed to be a minimum of 6 random sessions out of the 12 that they would go in and supervise that person in person. Because of COVID protocols in Rwanda, it was lowered to 2, but nonetheless, that didn't seem to be very necessary because there was still an average of 6 data points per non-specialist provider. So each non-specialist provider, of which there were in the broader study, almost 3,000, then we had about half of their data points for each of the modules.
Okay, yeah, because I think that's also something to consider, like longer term, and I'm sure like Vikram and other folks would agree that something the quality is obviously going to vary because you're in the real world and you can't really do much. And even if you get a recording of a session, you really can only depend on how is the client going to receive it. Even fidelity ends up becoming an issue, which is, I think, and I'm sure you're familiar, now they're trying to move more to this framing of adherence. So really kind of establishing what does it mean for fidelity to actually say that it's effective, which means how much do they actually have to adhere across sessions to actually say that it's quality. And I was thinking as well with the competence measure, I think that's great. You're gonna move into using the FAMACT and the competency tools that we have developed with EQUIP have really been useful for a number of reasons, and only being able to capture the exact behaviors that are supportive or not supportive in terms of building that competency. But to think about also in measurement that you have the opportunity to measure competency in a controlled environment, in addition to then adding that measurement in the real world, which I think could be really interesting to see whether or not there's an established competency by the end of the training before they're going in, before you start measuring that competency, and whether or not that then has an impact on X fidelity measurement that then you can combine as a quality score, as you've mentioned. And I think the last thing that I'll point out too as well is another aspect you could consider adding is attendance. I don't know exactly how it's fitting in here with this intervention, but the amount to which the folks are actually attending all sessions and how much of each session are they attending to, I think could also be a nice indicator to add into the whole question of what's really impacting the overall quality score, as it were.
attendance to the training or?
To the session, so the participants' attendance to the session, so you
Oh.
have your.
It's home visiting, so they.
Right, yeah, so they have to, that's what I'm saying, I don't think it's really applicable to this intervention,
But a
but
group setting, yeah.
and then some of them might, I think also just even the amount of sessions, if the session's time for 20 minutes, but it's only 10, maybe the kid is having a breakdown or has to take a nap, something like that, but in other intervention settings as well, I think this will be helpful to further extrapolate what is going on here between these variables that's creating a quality score.
Sarah?
Yeah, I was wondering, it's just really quick question, but also suggestion. So I was looking into research. So in my thesis, I actually worked on child development and parent and maternal and paternal stimulation. So just wondering, have you looked at differences between when you're looking at the caregivers? You mentioned some were fathers, some were mothers filling it out. Has there been any differences between the two?
This was all mothers filling it out because mothers were listing themselves in the homes as the primary caregiver. Where we have seen big differences is fathers and mothers both report on relationship dynamic measures that they have. And so we do see big differences between intimate partner violence scores, which is not really surprising, and reports on thinking about marriage or shared decision making. So sometimes we'll see different scores with that. For child development, they just had the mothers reported on it, and they don't have the father, secondary caregivers reporting on the same measures. So if they did, that would be really interesting. And I think there could be really big differences because of the different relationships they have with the parent, with the child.
Thank you, Laura.